Hi, everyone. My name is Carol, and today I'm going to be presenting an interesting case I encountered during my third year of medical school, which took place during an office visit at the Urogynecology clinic. So our patient was a 30-year-old woman, and she presented for evaluation of her current UTIs. Over the past year, she's had 8 episodes of dysuria, urinary frequency, and suprapubic pain, which improved with bladder emptying. She states that these symptoms did not occur in relationship to her menses, and during the appointment, she's not currently experiencing symptoms. She sought treatment for these episodes using an online telehealth service, which diagnosed her with a simple cystitis. She was prescribed an unknown antibiotic, which improved symptoms after a week-long course. During one of these episodes, she visited an emergency department and was told that her urine was negative. The remainder of the review systems was unremarkable. She denied urinary incontinence, abnormal discharge, hematuria, dyspareunia, constipation, diarrhea, dribbling, feelings of incomplete voiding, fevers, chills, and flank pain. For her past medical histories, she has a past history of migraines, no past surgical history. Her OB history is unremarkable as she's a nulli gravida. Her gyne history is also unremarkable, no history of STDs or abnormal PAPs. She has no known drug allergies, and her only medication is Tylenol as needed for migraines. Her family history is significant for type 2 diabetes and fibromyalgia in her mother, as well as hypertension in both her mother and her father. In terms of her sexual history, she's sexually active with one man, and they use condoms inconsistently. She denies other contraceptive use, including spermicide. In terms of her social history, she denies tobacco, alcohol, and recreational drug use. Now let's review her labs and her physical exam. As you can see, her vitals during the appointment were within normal limits. Moving into her physical exam, her constitutional, cardiovascular, pulmonary, and GI exams were unremarkable. In terms of her GU exam, we were unable to appreciate suprapubic tenderness, bladder distension, and CVA tenderness. Examination of her external genitalia was unremarkable. We next performed a speculum exam, which did reveal moderate tenderness to palpation of the anterior vaginal wall. However, we were unable to appreciate cervical motion tenderness or abnormal discharge, such as mucopurulent discharge. Next, she had a urinalysis performed during the appointment. As you can see, it is positive for white blood cells. She had 20 to 40 white blood cells per high power field, as well as a leukocyte esterase of 2+. However, there is little evidence of blood or bacteria on the CUA. So in terms of the differential diagnosis, I categorize these into 2 different buckets. This either is or isn't a UTI. In terms of a UTI, it could be a reinfection or a relapse. And risk factors for current UTIs include things such as anatomic abnormalities, such as urethral strictures, which could lead to urinary retention. Other risk factors include nephrolithiasis and pyelonephritis, but these don't really fit our patient's clinical picture because she doesn't have any flank pain, colicky flank pain specifically, which is related to nephrolithiasis, as well as hematuria. She also did not have systemic symptoms, which would be associated with pyelonephritis, as well as flank pain. Another potential cause of recurrent UTI could be an antibiotic-resistant or an atypical organism, both of which are pretty rare. Other risk factors include sexual activity, spermicide use, and poor hygiene. In the other bucket of diagnoses, this might not actually be a UTI. Possibilities include a urethritis, which could be caused by an organism causing STDs, which include herpes, chlamydia, and gonorrhea. Urethritis can also be caused by atypical organisms such as mycoplasma and ureaplasma, as well as other organisms such as trichomonas, gardnerella, and candida. Another possibility is an overactive bladder, which would usually present with urgency and frequency, as well as urgent incontinence, but our patient denies incontinence, and this diagnosis would not explain her pelvic pain. This also could be endometriosis. However, our patient states that her symptoms do not occur in relationship to her menses, and she also denied dysmenorrhea, dyspareunia as well. This could also be Behçet syndrome, and this is a rare systemic small and large vessel vasculitis, which is frequently associated with genital ulcers as well as arthritis and enthesitis. But our patient doesn't have arthritis and enthesitis, and she didn't mention a past history of aphthous ulcers. So while this is a possibility, it's a bit lower on our differential. Another possibility is pelvic inflammatory disease, which would be associated with systemic symptoms like fevers, pelvic pain, and possibly dysuria. But our patient does not have systemic symptoms, and we weren't able to appreciate mucopurulent discharge or cervical motion tenderness. And another possibility is bladder pain syndrome, but this is a diagnosis of exclusion that is typically given to women with bladder-related symptoms that are otherwise unexplained by infections or other causes. So we'll have to rule out the other causes first before considering this diagnosis. So the final diagnosis we came up with is a ureaplasma infection. And we performed a urine culture for atypical organisms, which demonstrated ureaplasma ureolyticum. This is an uncommon cause of GU infections such as urethritis and cystitis. This bacteria is a common colonizer of the perineum, though patients with it are usually asymptomatic. Patients do warrant treatment, though, if they have a compatible clinical syndrome, as well as isolation of ureaplasma from a normally sterile extragenital site, such as a urine culture. It's important to note that atypical organisms such as ureaplasma and mycoplasma are not detected on routine cultures. You have to specifically order a culture for a ureaplasma or a mycoplasma in order to detect it. It is also associated with pyuria on urinalysis, which our patient had, and the treatment includes tetracyclines such as doxycycline or macrolide, azithromycin. So as you can see, the treatment for this infection differs from that which is typically given for simple cystitis. So that's it. Thanks for your time, and let me know if you have any questions.